Well, thank you, Jim, and I wanted to thank the organizers for the opportunity to present today. This is an exciting conference, and I completely understand and appreciate that I am all that stands between you and various happy hours and dinner appointments, so I'll try to stay focused here. As Jim mentioned, I recently joined Intermountain Healthcare, and I want to talk today a little bit about clinically implementing cancer genomics as a programmatic approach in an integrated healthcare system. We've heard a lot today, and even at previous instances of this conference, about clinical cancer genomics and about genomics for all types of diseases and medicine. And a challenge that I think we frequently run into is how do we clinically implement these novel technologies? The advent of next-generation sequencing and digital PCR and other omics-based technologies is exciting, but their clinical application can be challenging, and that is what we've tried to address at Intermountain Healthcare. So as we think about cancer genomics, frequently the question that we ask, and I was asking myself as Hanli presented that last patient with whom I was intimately involved along with Jim Ford, I found myself asking, what is the appropriate setting to implement genomics? Is it at an academic institution, or would it be more appropriate at like a private or community practice? Or there are numerous integrated healthcare systems and healthcare networks where it might be advantageous. And I think each one of these settings actually has its own set of advantages and disadvantages. And so the answer to this question of what is the appropriate setting, since we're at the Personalized Medicine World Conference, is actually all of them, I think can be true. But I just want to focus for the next few minutes on our experience within an integrated system and what have been the challenges and what have been the advantages. So that'll kind of be an overview of the talk, is what, just briefly, what is Intermountain Healthcare, and then I want to tell you about our clinical cancer genomics and then give some of our outcomes. So Intermountain Healthcare is headquartered in Salt Lake City. Some of you may be familiar with it. It's comprised of 27 hospitals and over 180 clinics. One of its major advantages, and to be honest, a major reason that I joined was because they are both payer and provider. And that has significant implications, chief of which is that as a provider, when you identify some alteration that may be clinically actionable, it's easy to have a conversation with the payer side that is essentially the same organization. It is an open system. That's different than some of the other health networks which are closed. What I mean by open is that the facilities are open to any provider in a community, whether they are employed by Intermountain Healthcare or not, and they're open to any patient. So the patient can have any kind of insurance and get their treatments through this system. There are referrals from patients, for patients to Intermountain Healthcare from all over the country and even internationally. It's probably best well known for its institution of best practices, and kind of the major mission statement that drives all decisions there really is this attempt to deliver high quality, low cost care, and that's where cancer genomics has come in, and the realization that we think that new technologies are available that can allow us and enable us to deliver high quality care with cost savings and superior outcomes. So let me just talk a little bit about what this cancer genomics program is and how we've implemented it clinically. So on whole, our program consists primarily of genomic testing initially, and this is within a CLIA certified lab internally. And so patients' tumor samples are analyzed, and these are somatic mutations that we're looking for. We're not looking at their germline, and we're not doing whole genome or whole exome. This is a targeted list of genes. And in addition to genomic testing, we have a personalized medicine clinic where every patient with advanced or metastatic cancer that is appropriate, has progressed through various lines of treatment and is looking for other treatment options is seen and referred to this clinic. And then we have convened something called a molecular tumor board that is akin to standard tumor boards with which we're familiar, and I'm going to talk about that in a minute. And it's this group of experts that reviews the genomics for a patient's tumor and provides an interpretation of what that could mean potentially clinically. And then finally, we're developing a consortium of institutions that are like-minded and interested in participating together and learning one from another. So this is what our workflow looks like. A patient is referred to the personalized medicine clinic, and they are seen and educated by our physicians and our nurse navigators, and they sign a consent to proceed with genomic analysis, and either a previous historical biopsy specimen is obtained or a new biopsy in some cases is obtained. And you can see here the number of days roughly, and then this is analyzed in our pathology lab, and the sample is prepared, and next generation sequencing libraries are generated, and then molecular analysis occurs via next generation sequencing. And then then it's run through the analytics pipeline to determine which mutations are real and clinically meaningful. And this is being done and will be done with the aid of Han Li Ji's analytic pipeline. And then finally, outcomes are presented, or findings are presented to the molecular tumor board, who provides an interpretation. And then ultimately, results and treatment lie in the hands of the referring medical oncologist. Patients are sent back to the referring medical oncologist. And the final step that I don't have here is that navigation of obtaining the drug is also performed as part of this consultation service. And that is no small feat, as many of you know. And obtaining targeted therapies for molecular abnormalities involves an entire process. And I think we've had a lot of success in that regard that I'll talk about shortly. So this entire process, from the time that a sample is received in our lab through its analysis and finally delivery of results to a patient, is really managed in this regard. And the system that we've adopted is Syapse, who actually is here. And from the time that a test is ordered all the way through generation of a report, and then even capturing the outcomes, is managed through this system. The molecular tumor board that I referred to is comprised of both intramural participants, meaning medical oncologists, radiologists, pharmacists, nurses, and other support staff, as well as extramural participants, and these are experts in cancer genomics from other institutions, including the University of Oklahoma and Stanford University and others. And they web conference in, and we evaluate genomic results from a patient's tumor, and we provide an interpretation of what that might mean and how that could have a clinical impact. And in terms of a consortium, we have started to develop conceptually the possibility of pairing our data and our outcomes with other institutions. The biggest challenge, of course, with personalized medicine and with personalized cancer targeted treatments is that the N is always one, it seems like. It's really hard to generate big data when everyone is so diverse in terms of their genomics, and one way to overcome that is to partner with other institutions. And we're initiating that with Stanford, and that is also being developed with the help of Syapse. So I just want to finish the last few slides here talking about some of our outcomes. And I actually have lots of these, and I picked just a couple that I thought were of interest, and these are representative of multiple similar cases. I saw a 40-year-old gentleman just this last summer when I first arrived with metastatic colon cancer, and he had progressed through all previous lines of treatment. In fact, he really didn't have any other treatment options. But he was young, he had 5 kids, and he was still in good enough shape, and he wanted to do something. And genomic analysis identified a HER2 amplification, which we are now recognizing occurs in 4 or 5% of colon cancers. And so we were actually able to provide him with an anti-HER2 therapy, and what I'm showing here is the patient's CT scan from left to right over time. And unfortunately, when he was receiving his second line of chemotherapy, his tumor progressed as indicated by these 2 dark spots in the liver. This whole mass here is the liver, and these 2 lesions are the metastatic tumor sites involving his liver. Unfortunately, he had been progressing, and he was switched to a different cocktail of chemotherapy, and his tumor in the face of that again progressed. And that's when the genomic analysis was obtained, and he received TDM1 as an anti-HER2 therapy. And for the first time in the course of his treatment, his tumor began to regress. It responded dramatically, in fact, and over the course of about 5 doses, we've now had difficulty identifying the disease anymore, and he's doing great. And one anecdote that I just want to share is that he came into clinic and he said, we said, well, how are you doing? Your scans look really good. And he said, well, I feel well. You know, he was actually off all of his pain medications and had been gaining weight. And he said, but I have a major problem. And it kind of scared all of us. And we thought, oh, what have we not considered? And he said, well, I didn't renew my cell phone contract because I didn't think I'd be around to need it. And now here I am, still alive, and I need my cell phone, and they're going to charge me $40 more a month to have it. So we apologized to him. He's doing great. I want to share this case of a cholangiocarcinoma. This is a 50-year-old gentleman with metastatic disease who had progressed through multiple lines of treatment, and genomic analysis showed an FGFR2 alteration. And we were able to, in this case, give him pazopanib, which has an off-target effect on FGFR, and specifically FGFR2 it can. And really surprisingly, I don't usually see cholangiocarcinomas respond. Sometimes we can get them to be stable. You know, after chemotherapy, of course, it progressed. And right about here, it measured 8 by 8 centimeters. And after a few months on an oral therapy, it shrunk to 7 by 5 centimeters, and he's gained weight and is doing extremely well. He's been on that drug for about 6 months now. And I know that those are just a couple of anecdotes, but we actually have a much larger data set, and patients are doing extremely well, and we're measuring their outcomes as a way to determine whether genomics-based targeted therapies really provide or improve outcomes. Do they provide superior outcomes? And the answer to this question is we're waiting to find out, but the real important number here is that the number of patients that have actionable mutations and receive the targeted therapy is about half, which is we're very happy about. And that number is going to rise to around 80% or so over the coming months as patients get the drug that would be indicated by their genomics and as they fail standard of care. So I'll just conclude by saying and acknowledging all of these entities, specifically Intermountain Medical Group and the opportunity to speak here and these other institutions. And then, of course, my team down here has been integral as well. So thank you.